Hello everyone, my name is Indira Kommuru. I'm a pediatric neurologist and epileptologist at UT Health Sciences and Children's Memorial Hermann Hospital. The topic that I would be talking today is epilepsy and autism. I don't have any financial disclosures. So the objectives of this talk, these ones, I will be briefly going through each of them during my talk. So introduction. So autism and epilepsy are two common childhood neurological disorders that often coexist together. So the association between autism and epilepsy has challenged researchers to find the pathophysiological link between these two conditions. Okay, so it was Dr. Kommuru, a child psychiatrist, who first linked autism to epilepsy back in 1960s and suggested that autism was a disorder of a brain function. So it was around the same time the World Health Organization has classified epilepsy as a neurological disorder rather than a mental disorder. So I think these two events have challenged researchers to understand the relationship between autism and epilepsy, and if there is any commonality between them, any common pathophysiology between them. So not much research was done for the next few decades, the next 2 decades or so, because there were no clear definitions for epilepsy and in particular about for autism. So Dr. Lorna Wayne, she was a child psychiatrist, and she was the one who introduced the concept of autism triad and highlighted the importance of impairments in 3 areas: social interaction, language and communication, and repetitive behaviors among children with cognitive deficits. So I'm going to talk about a few definitions, which I think will be helpful throughout the talk. So seizure. So seizure is defined as a sudden disruption of the brain's normal activity, accompanied by altered consciousness and or other neurological behavioral manifestations. Epilepsy is defined as having at least 2 unprovoked seizures which are separated by 24 hours. So what do you mean by unprovoked? Meaning that seizures not caused due to fever or infection or any metabolic disturbances like electrolyte disturbances or trauma. Okay, so epilepsy syndrome, especially in pediatrics, is important because it gives you lots of information about the epilepsy. It kind of groups the features which usually occur together and gives a lot more information about the epilepsy the patient has. I can give you an example, childhood absence epilepsy. So when you see that, you can understand that the kind of seizures the child has in this epilepsy syndrome is absence seizures, where they stare briefly, unresponsive, some automatisms like eye blinking, some chewing movements of the mouth, and the last few seconds, and then they're immediately back to baseline. They happen multiple times during the day. Usually you see them in children of school-going age, early school-going age, like 5 to 8 years of age. Usually it's genetic cause, although there is no one gene to say that causes these seizures. The children do well with medications. The seizures are well controlled. Children can have some learning problems, but usually they respond well with medications and they do well. And the EEG shows a specific pattern showing what we call, I'm going to show later on, what we call like spike and wave discharges on the EEG. And usually these children do good. And sometimes they can outgrow these seizures in late adolescence. So it gives you a lot more information when you describe epilepsy as an epilepsy syndrome. In a more recent term, epileptic encephalopathies, according to International League Against Epilepsy, this is a condition in which the abnormal activity, the epileptic activity or the abnormal EEG activity, this contributes to severe cognitive and behavioral impairments, which is above and beyond what might be expected for the underlying cause alone. And these impairments can worsen over time. The examples for these epileptic encephalopathies are West syndrome. You might have heard of it, where the children have infantile spasms. Okay, and Lennox-Gastaut syndrome is another example of epileptic encephalopathy, Dravet syndrome. So these are some of the examples where the EEG and abnormal activity of the EEG contributes to lots of behavioral and cognitive impairments. So we kind of treat them aggressively. So this is the EEG in a child with childhood absence epilepsy. So you can see this low voltage activity, this is the normal background, this is child is awake, and this high voltage activity that you see in the middle of the page, that is the abnormal activity. That's what we describe as spike, a sharp, this sharp component that you see, and like a slow wave. So this is seen in all the leads recorded on the patient's head. So this is more like a generalized epilepsy. Okay. And then autism spectrum disorder. So according to Diagnostic and Statistical Manual of Mental Disorders 5, DSM-5, the child has to have persistent deficits in the 3 areas to classify them as autistic spectrum disorder. Okay, social communication, interaction, and restricted repetitive behaviors. So they have trouble with verbal, non-verbal language. Even if they speak, they have very limited language. There is most of the times they repeat the questions. Their interaction with the children of their age, with their peers, is not as expected for their age. They have poor eye contact. They also have restricted and repetitive behaviors like hand flapping and sensory issues. They have sensory issues to noises, to food textures, and also the way they play. They line up their objects instead of playing with the objects. So they have these deficits in these 3 areas, and if they're persistent, that's when you classify them as autistic spectrum disorder. So now we no longer use Asperger's syndrome or PDD, those kinds of stuff. Okay, so everything is grouped together as autistic spectrum disorder. So what is the prevalence of autism and epilepsy? So autism, according to CDC, 1 in 54 children are identified with autistic spectrum disorder. Okay, and it's more common in boys, 4 times more common in boys than in girls. And epilepsy affects 0.5 to 1% of children. Okay, so approximately 30% of children with autism or autistic spectrum disorder have epilepsy, and about 15 to 30% of children with epilepsy have autism. Okay, so they co-occur. So in studies of children with epilepsy in an English school system, they found that 21% of children with epilepsy had autism. Okay, and then there is this meta-analysis of studies between this time period that you can see there. The pooled prevalence of epilepsy was 21.5% in individuals with autistic spectrum disorder who had intellectual disability, and it was much lower, 8% in autistic children who didn't have intellectual disability. So this tells you that children, autistic children with intellectual disability, they are at higher risk for epilepsy. Okay, so again, this large cross-sectional study, which evaluated around 5,800 people with autism spectrum disorder, the prevalence of epilepsy differed with the age they chose. Okay, so it was prevalent around 12.5% in children between 2 to 17 years when they chose younger children, and the prevalence increased to 26% in those 13 years or older. Okay. So I'm going to talk a little about historical perspective of autism and epilepsy. So it was thought that early onset epilepsy was related to autism. Early onset epilepsy is one of the risks for autism. Okay, this Finnish study in 1981 found that 12.5% of the children with infantile spasms developed autistic spectrum disorder. So like we discussed, infantile spasms are early onset seizures, which are seen in children younger than, usually in their infancy, younger than 1 year of age. Okay, and they have this body jerks happening in cluster. they can have cognitive and intellectual impairment. So they found that 12.5% of children with this infantile spasms develop autistic spectrum disorder. Okay, Deakin and McMahon studied that 183 children with autistic spectrum disorder. They studied 183 children with autistic spectrum disorder, and they found that they're at risk for seizures, early onset, early peak of the seizures. But the other interesting finding they found was the highest prevalence of seizures was at the ages of 11 and 14, between 11 and 14 years. That means at puberty or adolescence age. So there are two peaks in children with autism. So there are two peaks for increased seizure risk. One is early onset before 5 years of age or so, and the other one is puberty and adolescence. Okay, so there are two peaks. So this suggests that during adolescence, the cause for the seizures in adolescence in children with autism was thought to be the ongoing pathological process. Whatever the process that's causing the autism, that is also putting them at risk for seizures. Okay. So in 1980s, Hunt and Dennis studied 89 children with tuberous sclerosis. Okay, I'm going to discuss a little about tuberous sclerosis later on. But they found that 57% of children with tuberous sclerosis and infantile spasms had autistic spectrum disorder. So infantile spasms are common in children with tuberous sclerosis, and 57% of them had autistic spectrum disorder. So from this, we know that early onset seizures, infantile spasms are at increased risk for autistic spectrum disorder. So other important observation that they have made was that between autistic spectrum and epilepsy was that children with language impairments or intellectual impairments had the subclinical status epilepticus on their EEGs when they did the EEGs. So these are the children who did not have clinical seizures but had some intellectual impairments, language impairments, and mainly regression in their language. And the EEG showed abnormal, those spike and wave discharges on the EEG, especially during the sleep. Okay, so it's called subclinical status epilepticus on the EEG. So it was Lanto and Kluckner who were the ones who described first this kind of specific pattern on the EEG back in 1950s, and they associated this with language regression. Okay, and again, I'm going to talk a little about language regression, autistic regression a little later on, the differences between them. Okay. So overall, whether the epileptiform activity is the cause for the language regression, is it causing the language regression, or is it an epiphenomenon like secondary to an underlying process, underlying pathology? It's a topic of debate, and it continues to be controversial. Okay. Tuckman and Rapin, in a study of language regression in 585 children with autistic spectrum disorder, they found no difference, okay, in the proportion of children with epilepsy or epileptiform discharges who had regressed before or after 2 years of age. So again, Tuckman and colleagues, they found that disorder, okay. So Rossi and colleagues, they were the first to speculate that genetic factors were common in both the disorders, both autism and epilepsy, and likely this accounted for the co-occurrence of autism and epilepsy. Okay, so children with autism can have all different kinds of seizures. Okay, but the most common seizures that they found were the partial complex seizures or focal seizures being the most common. Partial complex seizures, meaning the child is unaware, unresponsive, or partially responsive. Again, they can have some kind of movements, but not the typical generalized tonic-clonic seizure. Okay. So later on, or more recently, Sunderland et al. Provided evidence again that children with autistic spectrum disorder, the individuals with epilepsy are at highest risk for developing autistic spectrum disorder if the epilepsy happens early on in the life. And the other important finding that they also found was that the siblings and offsprings of people with epilepsy, they are at higher risk for autistic spectrum disorder, okay, even if the siblings and offsprings don't have epilepsy, okay. So this is just a picture that I just wanted to show you. This was published by Hashimoto et al. In 2001. This is to show that the interictal epileptiform discharges, meaning when you do an EEG in children, when they're not having seizures, in between the seizures, or anytime when they're not having seizures, then the EEG shows some of these spikes or shock waves that we discussed. So they studied about these interictal spikes, and the first one, the top one, is the controls, meaning children who didn't have seizures or epilepsy, but they did EEG for some other causes, and they found abnormal discharges, okay. And the bottom one is the interictal discharges in children with autism, but not epilepsy, but they did EEG for other causes, and they found these abnormal discharges. So they were more, in children with autism, these abnormal discharges were located more in the frontal region, the front of the brain, when compared to their controls, okay. So your frontal region of the brain controls more like your attention, behaviors, all those kinds of stuff that we see the children with autism have issues with. So this is language regression. I just wanted to talk a little about this because sometimes we see parents, parents of children with autism saying that my child have regressed. He was speaking few words, about 5 to 10 words, and then he regressed. He stopped speaking those words. He had some body language, some waving bye-bye, and those kind of stuff has also regressed. So there were studies to find out whether this regression was associated with any seizures, epilepsy. And what the researchers have found that, Shinar et al. In 2001 showed that seizures are more common in children who regressed after 3 years of age, okay, when compared to children who regressed before 3 years of age. So in general, in children with autistic regression, you see this regression between 18 to 24 months, okay? Whereas this true language regression, so these are the children who have been speaking normally, full language, and then they regress. So this kind of regression, this kind of language regression, that was associated with seizures and epilepsy rather than the autistic regression, okay? So McVicar et al. In 2005, they compared the overnight EEGs and prolonged EEGs of children with isolated language regression versus those children who had language regression and more like autistic regression. And then they found that children with isolated language regression were the ones who were likely to have abnormal discharges or epileptiform discharges on the EEG, mainly focal discharges, than those children who had language regression, more like autistic regression, okay? So, so these studies suggest that children with autistic regression can be differentiated from those children with just isolated language regression, or the ones that we talk like Landau-Kleffner syndrome, right? So we can differentiate both of those based on the age of onset, whether it was before 3 years of age or after 3 years of age, or is it primarily language regression or more like an autistic regression? It's not just language, but also behavior, stereotypies, all this, more like a global regression, and also sleep-related EEG findings based on frequency of epileptiform activity. So this is just to show you that there are many genetic syndromes in which both autism and epilepsy coexist, okay? For example, Angelman syndrome, Down syndrome, Dravet syndrome. So you can see the percentage of autistic spectrum disorder prevalence and seizures. They vary depending on different studies, but both co-occur in these genetic syndromes, again, tuberous sclerosis, and all these syndromes, okay? This is from an article published by Buckley et al. So I'm going to talk a little about tuberous sclerosis, because this is a genetic condition in which there is co-occurrence of epilepsy and autism. Okay, so tuberous sclerosis is an autosomal dominant disorder, which is characterized with presence of these tumor-like lesions in multiple organ systems. Okay, in your brain, kidneys, heart, etc. So, so these children with tuberous sclerosis, like we have seen before, have higher incidence of infantile spasms, intractable epilepsy, cognitive disabilities, autistic spectrum disorder, and other behavioral issues. Okay, so patients with in this tuberous sclerosis patients, autistic spectrum disorder, patients with autistic spectrum disorder, they had early onsets of seizure, and also they had more frequent seizures. And the EEG showed electroencephalogram, that's the recording of your brain. It showed significantly greater amount of interictal abnormalities, epileptiform abnormalities, mainly in the left temporal lobe, when compared to those patients who did not develop autistic spectrum disorder in tuberous sclerosis patients. So I think that autistic spectrum disorder may be associated with persistent seizure activity early in the development, especially when your brain regions, when it occurs in the brain regions which are important for development of social perception and communication. So supporting this hypothesis is that if you treat tuberous sclerosis patients early on, the epilepsy in tuberous sclerosis patients, if you treat the epilepsy early on, then they are at less risk to develop autistic spectrum disorder. Okay, so so they have studied, this long-term study have studied infants with tuberous sclerosis, and they followed for like 3.5 years. And they have seen who developed co-occurring epilepsy between children who were treated early on with vigabatrin and children treated later on. So you can see that children who were treated with vigabatrin early on had only 9% development of epilepsy when treated later on. So this tells you that like early treatment of seizures in tuberous sclerosis seems to clearly reduce the risk of autism spectrum disorder, but might not eliminate it. So I'm going to talk briefly about the pathophysiology behind autism and epilepsy and behind their co-occurrence. Okay, so we now know that both are heterogeneous disorders. They have multiple genetic and non-genetic factors causing them. So which are involved with neural development, the way the neurons in the brain develop, the way they proliferate, the way the neurons proliferate, the way the neurons migrate, and the synaptic transmission, meaning the way how the neurons, one neuron communicates to another, and the brain network activity. Okay, so I think these both disorders have commonality with this underlying neural development, synaptic transmission, and brain network activity. So there are lots of consensus from both animal and clinical studies that again autism is also a disorder of aberrant brain connectivity. So the functional MRI, magnetic resonance imaging studies, and electroencephalogram studies in patients with in patients with autistic spectrum disorder showed that there is over-connectivity and also under-connectivity in different regions of the brain. Some of the regions, locally, there is over-connectivity, and different regions of the brain, other regions of the brain, there is under-connectivity. I'm going to show a picture on my next slide. So in case of comorbid epilepsy and autism, there is imbalance of excitatory and inhibitory ratio in selected regions of the brain, and this may drive this over-connectivity. So this is just a cartoon or a diagram that I got over internet, just to show the connectivity of the brain. So in children with autism, so there is increased local connectivity. So local regions are over-connected, and when distant regions of the brain, so like front to the back, so those kinds of stuff, the distant regions are connected. Again, there is also debate regarding this. So, but now again, evidence is accumulating that the co-occurrence of autism, autistic spectrum disorder, and epilepsy may be explained by the same nascent insult. So whatever insult the brain has undergone early on in the life is affecting the way the brain is developing, the way the neurons are proliferating, the way the neurons are migrating, the way the neurons are establishing synapses. Okay, and there is the way the brain is connected, the networks are connected. So the insult that's happening early in the life is causing this one, and this is finally expressed as either autistic spectrum disorder or as seizures or as both. Okay, so this is, I think, the most recent pathophysiology. So, how do we, so when do these children with autism see a neurologist? Because most of the times, autism is diagnosed by pediatricians or developmental pediatricians or psychiatrists, or sometimes maybe neurologists. But most of the times, neurologists are not the ones who diagnose autism. So if a child with autistic spectrum disorder has a seizure or new onset seizure, or has events or episodes that are concerning for the seizures, it's the time they see a neurologist. Or if they have developmental regression, especially the language regression that we have discussed in children over 3 years of age, or they have autism with global developmental delay, with motor problems, like they're having weakness in the extremities, or they're having difficulty with walking, they're not walking, or they have an abnormal neurological exam, they have increased tone, so those kinds of stuff. So that's the time they need to be referred to the neurologist and be evaluated by a neurologist. So what kind of workup does the neurologist do? Yeah, we get detailed history, do a detailed physical exam, including neurological exam. If the child was not referred to audiology before, the child needs to be referred to audiology to make sure the hearing is fine, and that's not the cause for delayed language. And some genetic workup, including chromosomal microarray, to see if there are any deletions or duplication in the chromosomes that can cause autistic spectrum disorder and epilepsy, Fragile X syndrome, or Fragile X testing, or Rett syndrome testing, especially in girls, and an epilepsy panel to check for any mutation in the genes that can cause seizures, and autism as well. And metabolic testing to check for electrolytes, and also we check for other metabolic testing as well. We do check for amino acids in the blood and also in urine, so those kinds of stuff. And we do an electroencephalogram, EEG, that is to check the brainwave activity. So either we do a routine EEG, which lasts for like 30 minutes, or sometimes we do a prolonged EEG for 24 hours or so to see these brain wave abnormalities, or sometimes we want to capture those episodes and see if they are seizures or not, and an MRI of the brain. So MRI of the brain is not done in all children with autism. It's not required in every child with autism. But if there is a concern for seizures or an abnormal neurological exam or regression, those kinds of stuff, then we do an MRI of the brain as well. Okay, and then finally the treatment. So children with autism and also epilepsy, they need behavioral treatments and other therapies, physical therapy, occupational therapy, and speech therapy. And also, if the child had more than 2 seizures, then we usually start them on anti-epileptic medications. Okay. So the anti-epileptic medications that we use in children with autism, kind of the same way that we treat other children with epilepsy who doesn't have autism. Sometimes children with autistic spectrum disorder can have behavioral issues. So we try to avoid those anti-epileptic medications that can further worsen these behavioral issues. But otherwise, we kind of treat the same way. And then these children can also have other comorbid conditions like ADHD, attention deficit hyperactive disorder. Sometimes they need to be on medications for that to help them with focusing, and also sometimes antipsychotics for them to psychiatry as well. They need to be on antipsychotics to help with their behavior, their agitation, and aggressive behavior, etc. Okay, so that's all for me. These are my references. And thank you.